Okay guys, I think we're going to get started. I tend to be a little bit of a restless personality, so please bear with me because I'm going to pace and move around a little bit. And my Italian heritage is going to come out as I have some wild flinging arm movements. So I apologize for that in advance. So my name is John Pugh. I'm a general child neurologist. I've been here in Albany about 6 years. And tics Tourette's is probably about 10% of what I do on a daily basis. I have no disclosures, but I am going to hit upon off-label prescribing. Most of the drugs that we use for tics and Tourette's are actually off-label, and that's especially true in children. I want you to recognize indications for the treatment of tics. I want you to be able to help to assist families in picking out symptoms that need to be targeted and addressed, and have some name recognition for different medicines that you can use in prescribing. I would say that only about 20% of the kids who actually get to me leave my office with a medicine for tics. And I think that's an important thing to remember. A lot of the time, it is adequate to see the patient, do an assessment, explain what's going on, and counsel them on what to expect in the future. And that I find is helpful for the vast majority of the families that I work with. When I treat tics, I don't treat the tics per se. I try to deal with the impairment or the problem that the tics are causing. I treat people who have pain from their tics. So my brother has Tourette syndrome, and when he was younger, he had a really annoying tic that was like this. And he would do that tens of minutes on end, and by the end of it, his neck would hurt. That's an indication for treatment. My daughter is 14 and she's in high school, and she's had tics since she was about 8 years old. And she just has a little simple eye blinking tic. Most of the time it doesn't cause her a problem, but as she's gotten a little bit more advanced in school, there are some other kids who have noticed it. So social stigma to avoid the problems with bullying that we've discussed can be an indication for treatment of tics. Finally, if it's impairing your ability to function, I have some people who blink their eyes so frequently that they just can't sit down and read a book. That's a reason to treat tics. For me, the goal is not to get rid of all tics. I normally can't get rid of all tics. I limit the tics to get rid of the disability or impairment that they're causing, and I try to focus on improving quality of life. I do mainly medical management. One thing that we want you to walk away from, and what Matt is going to talk to you about in a little bit, are behaviorally managing tics. And I think that is really the emphasis that we want to leave you with. That being said, it's hard to get in to see a child psychologist or someone who can prescribe medicines to do, who can do the behavioral therapies. So I often use medicines as a patch or a Band-Aid to take the edge off while we wait to get something more definitive. And that's a reasonable strategy for someone who's in primary care. I also try to be very cognizant of comorbidities, treat them as they come up, and try to choose medicines that are going to pull double duty for me. Nobody's shown something like this, but you've heard several people talk about it. Tourette syndrome, tics, it's this big giant spectrum and has lots of different comorbidities. You'll have people who just have tics. You'll have people who have tics and ADHD. You'll have people who have tics, ADHD, and OCD, and then you have people who have the quadfecta, and they have the behavioral problems, impulse control, and even learning disabilities. And if you're only working up here and treating the tics, you're not going to do a good job of managing the patient overall. So it's really critically important that you assess for and have your treatment strategy include all of these comorbidities and all these other issues. People have already alluded to this, and one of the problems with tics is that they tend to wax and they tend to wane. So I have tics, and they really only come out when I'm really sleep deprived, really overworked, when I'm on service, or generally in November when I'm done with my Neurosciences 2 class. And then I will often have eye blinking tics and some facial tics, and some of my residents have picked up on it when they're especially astute. There are times when I might benefit from a medicine to keep them under control. But 90% of the time, I'm generally able to go about and nobody knows about it. And sometimes it can be tough because you might catch someone as they're waxing and then they're waning. I always get those reversed. Which one's getting worse? Waning? I don't know. Sometimes you get someone at the peak of a cycle and at the trough of a cycle, and it's hard to know when to treat. It's also hard to know if your treatment is actually being effective or if you're just seeing the natural improvement over time. So if you do treat someone with tics, you should really go in for the long course over months, not over days to weeks. There are only 3 medicines that are approved by our Federal Drug Administration for the treatment of tics. These are medicines I almost never prescribe. I can count, I've never prescribed Haldol. I've managed 2 people on ORAP, Pimozide, who came to me on Pimozide. And I've prescribed aripiprazole once. So if that's my prescribing experience, then I would encourage you guys not to touch these. They are, hands down, the most effective. These will get rid of most tics very well. But they are the last medicines that I ever use. I assume that other providers have a similar flavor. These are the groups of medicines that people generally find most helpful. And I kind of broke them down by class, and then the agent within the class, and then some special notes. So the alpha agonists, things like clonidine and guanfacine, are very helpful. And this is normally where people will go to first. These can be very helpful for people who tend to be a little more on the hyperactive side, people who have a little bit of trouble sleeping or winding down at the end of the day, a little helpful for people with comorbid ADHD. The next group of drugs that I'll often go to are either the antidepressants or anti-epileptics. Topiramate is really a wonderful drug for tics. And I find topiramate to be especially helpful if someone is a little bit overweight or if someone has very significant headaches, because topiramate is an excellent drug for the treatment of headaches, and it tends to be a little bit of an anorexic. Antidepressants are especially helpful if you have a lot of comorbid anxious OCD symptoms, and drugs like fluoxetine or sertraline are really, really helpful, especially if you have someone whose tics tend to get worse during periods of anxiety or are really driven by anxiety. As I said, the antipsychotics are medicines that I really don't play with much at all. I think they do have their place, but they should be downplayed. And I think that Dr. Morsi is going to talk a little bit later about some of the more interesting data coming out on dopamine depleters. I'll make a copy of my slides available to everybody so you don't need to jot down all of this information, but I thought it would be helpful for me to give you a general range of dosing for some of these. When I'm dosing Topamax, I generally dose it at the same dose I would do for headaches, which is normally once a day just at night with 25 to 100 milligrams. And that's generally pretty effective for most of the kids I treat. Sometimes I have to go a little bit higher. Someone already alluded to this a little bit earlier. This was a meta-analysis done by folks at Yale, and they looked at something like 22 studies. And they looked to see whether or not stimulants made tics worse. And the bottom line is that as a population, as Dr. Jaffe had said, they don't. Stimulants cause tics at about the same rate as placebos cause tics. So don't be afraid to prescribe stimulants, your best medicine for the treatment of ADHD, just because someone has tics. And then I think you referred to this study a little bit earlier. This is another study that looked at what drugs are good for the treatment of tics in patients with ADHD. And they had 4 treatment groups. They had a group that got nothing, they had a group that got clonidine, they had a group that got methylphenidate, and a group that got both. Everybody got better, but the people who got the most better were the ones who got the combination clonidine and methylphenidate. So don't be afraid to use stimulants if you're treating ADHD in someone with tics, the bottom line from those 2 slides. In terms of anxiety and OCD symptoms, I'm not going to dwell upon this too awful much. I think Dr. Jaffe hit upon it relatively well. But you can, if you have significant anxiety or OCD, use your antidepressants, especially sertraline, and fluoxetine. Be aware of the common side effects. In terms of medically refractory tics, this hadn't come up at all, but Botox can be helpful, especially if you've got facial tics. If you paralyze the muscle, you can't tic. So that can be one helpful treatment. People had already alluded to this, which is deep brain stimulation. Now, I've only known about 4 patients in my life who got deep brain stimulation, and they were all from Cincinnati, and they were all late adolescent patients. And I think that the comments that were made earlier about the plasticity of that basal ganglia circuit and how it gets better with age, and tics tend to get better as you get into adolescence and into adulthood, would argue against doing this sort of thing in children. But in an adult who has medically refractory tics that have failed multiple medicines and that have failed good behavioral regulation, this could be an option. And that's all I wanted to hit upon. I'm going to turn it over to Matt.
Thank you. Just wondered if there were any questions about medications.
I just make one comment about Botox. I think that's a really good thought. Too. So I do Botox as part of my treatment of different movement disorders, and so tics can be a little bit tricky. The evidence is okay. I'd say, again, it's in specific situations. You know, eye blinking, facial are good, facial grimacing, and sometimes neck extension. What's interesting is that there are some studies maybe to suggest that it actually improves that premonitory urge component. So you want to be careful, though. Say my tic is I have to go down this way. To do this is the SCM and the scalenes, but if you weaken them, that urge is still there in the back, so are they really going to kind of get relief? Whereas with a neck extension tic, the direction of the movement is in the same area as where the premonitory urge is. And so again, you have to be very careful, but I do have a select few patients that I do focal botulinum toxin for bothersome tics.
Have patients begun asking you about medical marijuana, and where would you go with that?
They have. The short answer is that there is no adequate data to support the use of medical marijuana for the treatment of tics, especially in children. There is no good scientific data. There is no good scientific data to support the use of medical marijuana in the treatment of tics, especially in children where we do not know the long-term side effects of these medications on a developing brain.
So now I'm going to talk a little bit about non-pharmacologic treatments. I forgot to mention earlier that I do have some disclosures to make. I've been funded by the Tourette Association for a couple grants, and also I've received payment for talks where we go around the country for the CDC and also to do the Behavioral Therapy Training Institute. I actually got my start, so to speak, in Tourette's in about 2006 when I joined Johns Hopkins as a postdoctoral fellow. At the time, prior to that, I was actually working in serious and persistent mental illness, and I was doing EEG and fMRI work with adults who have schizophrenia, and I met John Walkup at a barbecue, and he told me about this treatment trial where they were evaluating a new treatment for Tourette's. And I really didn't know a whole lot about Tourette's, and I said, well, you know, my assumption is that you're using medications. Is that correct? And he said, no, this is actually a behavioral treatment. And I said, I knew enough to say, you know, in fellowship, you know just enough. I said, oh, you must be treating the comorbid conditions. And he said, no, we're treating the tics. And I said, with a behavioral treatment? And he said, yes. Now, when I started at Hopkins, there were a number of different randomized controlled trials going on at the time for all sorts of childhood disorders. And it seemed that nobody really was all that interested in doing the tic disorder study. But I found that it could be a game changer. So we've heard about the medications that have been shown to be effective, but oftentimes they're associated with side effects, and the idea that a behavioral treatment could be effective in reducing this long thought to be strictly neurologic condition was fascinating to me, and I'm glad I got good advice, which is never turn down a job you haven't been offered. So I went through the interview process and was able to actually see some kids in the study at that time, and I was fascinated by the prospect of this being an effective treatment. There have been no head-to-head trials, medication versus CBIT. But this graph here demonstrates that, at least suggests that CBIT can achieve similar reductions in tic severity to some of the leading medications, the antipsychotic medications. The number needed to treat is 3, which means treating 3 kids, there's a chance you'll get one of them significantly better. The improvement percentage was about half of the kids that were randomized to the active treatment. HRT here just means habit reversal training. People ask me that question about that all the time. What's the difference? Well, habit reversal training was a precursor to CBIT. CBIT added additional elements. Am I blowing your eardrums out? No, I'm good? Okay. I just want to show you this little video because, I've kind of carried this around with me for a while. I was asked, early on, well, can this actually work? And this is an extreme example. I'll just tell you that right off the bat. But this is a little video I made to demonstrate how effective it can be. This is a young man who had lots of co-occurring conditions, particularly anxiety disorders. This video was made just shortly after I gave him a strategy for managing his most problematic tic. So just there, we gave him a cue to use the strategy that we provided him, a competing response for just his vocal tic, which was actually a muted swearing tic. And you'll see his diaphragm moving up and down in a slow, rhythmic way. His lips are pressed together, his teeth are lightly clenched, tongue on the roof of his mouth. And then people said, well, can he do anything else? He can manage this tic, but can he effectively function? And this is him about a week later. Interacting with one of my research assistants. For this young man, just treating this one tic allowed him to go back to school. And I just wanted to point out that sometimes that's all it takes from a tic standpoint. These co-occurring conditions, as has been mentioned frequently today, are much more problematic, but sometimes there are severe tics, particularly the more complex, intense, and directly interfering tics. And sometimes we can get some significant relief by effectively targeting them, and now we can do that non-pharmacologically. Generally, kids with comorbidities respond about as well as kids without to CBIT. 6-month follow-up, there were some additional decreases after the acute phase of treatment in anxiety, disruptive behavior, family sharing. This is not to suggest that CBIT produces reductions in these co-occurring conditions. This is just to suggest that the kids who responded well to this intervention looked good beyond just their tics during the follow-up phase. We are now looking at the long-term effects of CBIT. We have a trial underway to follow the 126 kids that we originally randomized to one of these 2 treatments. We're following up with them now about 10 years later, so they're in their early 20s. And Jen Schild, who is here today and helped us organize all of this, and we give her a little round of applause since she's in the room. She's going to be so mad at me for doing that. But she's actually conducting interviews with young adults now who were in the CBIT trial, and what we're finding is that the kids are actually doing pretty well tic-wise. So here's some of the pilot data. CBIT is the lighter bar on the left, and the green line represents a YGTSS, or Yale Global Tic Severity Scale rating of about 14. Anything below that we see as being asymptomatic, and this demonstrates that the kids who were randomized to CBIT in the pilot study that we did seem to be doing pretty well tic-wise, and I think the interviews largely suggest something similar, although we have to look at the results when we have a bigger N. But from a comorbidity standpoint, I think these kids are still struggling quite a lot. And again, we also had aging out effect here. As was mentioned earlier, Dr. Bennett is actually involved in, I think, writing up the results, or maybe it's already been published. extending this to a lower age range. So CBIT was originally 9 to about 18 because there was a concern that if you didn't have a premonitory urge, it may not be effective. But now we found that kids that are younger probably do have premonitory urge experiences. They're not very reliable reporters about it, and sometimes they lack the self-awareness. But you can still do CBIT in kids that are younger. It's also been shown to be effective in adults, although perhaps not quite as effective in adults, and we think that this may be due to the fact that about 1 out of 3 people who have tics in childhood will persist in having adult tic disorder, and it may be more challenging to treat tics the longer that they've gone on. So we definitely want to identify and treat earlier on. One of the questions I was asked is why treat tics at all? If comorbidity is really the issue and, the worst period of time is 10 to about 15, why do we need to do anything? And I think it's just a matter of trying to use the safe, effective, non-pharmacologic treatment to reduce the kind of pain and suffering that can occur during those periods of time, and we may help to improve people's quality of life earlier than just waiting till adulthood. And there was a period of time where people were very concerned about using medications to treat tics, and CBIT was not online yet, and so we're really glad to have non-pharmacologic treatment that's now become the frontline treatment for tic disorders. There are various resources that clinicians and parents can access to learn more about CBIT. I'm happy to answer any questions people might have. What time are we ending? About 5 minutes. I just wanted to run through a couple other things just to let you know. Dr. Morris will be speaking a little bit later, helped us to do at this pilot study where we did a rapid version of CBIT. So instead of doing 8 sessions over the course of 10 weeks, we did 8 sessions in 2 weeks. And this is not a direct comparison, but as you can see here, the orange bars represent the % reduction in tic severity, and we find that this rapid treatment had similar reductions in tic severity after 1 week as to the traditional treatment at 5 weeks, and then we had similar reductions at 2 weeks to the traditional treatment at 10 weeks. And so we thought this might be a good thing to be able to do for kids who are really struggling with tics and are on our inpatient units or are traveling from far distances. Mike Kimley, who's at the University of Utah, has worked with Doug Woods and other folks to develop this Tic Helper, and this is a good online resource. So it's really an interactive platform so people can learn how to manage their own tics. We don't think this is going to be effective for everyone, but we do think that there are people who are struggling with tics that are not particularly severe, and this might be a good way to address the need because it is hard to find CBIT providers, even though the Tourette Association has done an excellent job of trying to train providers all over the country. Don't pay attention to the goofy-looking guy in the bow tie, but this is our attempt at parent-directed kind of instruction through a DVD. This study is underway, but Harvey Singer, who's a pediatric neurologist at Johns Hopkins, and I put this video together, and what we're finding is that some parents may be able to utilize this, but probably more often they need some additional support from a therapist, and so we want to look at kind of partnering things like a DVD for people who live in remote outlying areas with some access to professional. The other thing I just wanted to mention, this has not been studied. I would love to do a study of this, but we developed a brief transdiagnostic parent training, as I was talking to Dr. Morris about. As my tic clinic at Johns Hopkins grew, I started to get kids who were in my office that were struggling in much, much more complicated ways than just tics because of their comorbidities. And for years, I kind of tried to hierarchically organize their treatment needs, the various conditions, and then use what we know about treating those conditions to treat them effectively. But every time I tried to address, say, OCD, some of the other conditions would be flaring up. And so really out of desperation, I took a long extant intervention parent management training, which has been used for kids who have ADHD and disruptive behaviors for years and been shown to be very effective, and tried to kind of whittle it down to be a more pragmatic delivery so it could be used by pediatricians, psychiatrists, possibly to address the kind of transdiagnostic issues. And so we call it, this slide's not updated, but it's brief transdiagnostic parent training, and we think that this is perhaps a very effective frontline intervention for addressing kind of complicated comorbid cases so that people don't kind of get lost in the weeds, so to speak. And lastly, I'll just say that I look at this kind of parenting approach as a scaffolding upon which you can build other treatments very effectively, like CBIT, exposure and response prevention. You get the idea. So that's my last slide. Any questions about CBIT? Yes. Yes, the longitudinal research about CBIT is in the works. We have collected probably about half. Where'd Jen go? Oh, she left. Probably about half of this. Oh, there you are. I'm sorry. About half. About half of the 126 kids thus far. We're hoping to get the sample up to about 70, 80%. It's really actually fascinating trying to find these people now that they're young adults. And what's been amazing to me is almost everybody that we've gotten on the phone has wanted to participate. I think that's a lot due to how charming Jen is with these youngsters. But it just speaks to the investment of patients and families in terms of kind of understanding what we can do and how effective are our treatments right now. So hopefully in the next year or so we'll have those results published. Yes. Yeah, so
there has to be a level of participation and desire to improve?
Well, so one of the things that I think happened is, we found for conditions A, B, C, D, E, F, and G, in terms of, anxiety disorders, OCD, tics, ADHD, we figured out what was effective, but, most of the cases that we see clinically have A, B, and C, and we know almost nothing about how to treat them effectively, and we're learning all the time, but we can't get large randomized controlled trials to determine that. And so most of us at large academic medical centers are developing kind of informal algorithms to try to address these. And I think one of the brief transdiagnostic parent training was actually born out of a request for a clinician's guide that Joe McGuire, who's now at Johns Hopkins in my old position, he and Tanya Murphy and Eric Storch developed a clinician guide to kind of help clinicians to understand how to diagnose and treat kids with Tourette's. And they asked me to do something about the comorbidity issue, so comorbid disruptive behaviors and the like, and that's really been done before. And so I wrote the chapter to address complicated comorbid cases, including kids who have tics, ADHD, disruptive behaviors, kids who have Tourette's, ADHD, and OCD. And so, yes, I do think we can effectively treat. And also, I'll just mention, a precursor to BTPT was actually Dennis Sukadlowski's work at Yale, and he and Larry Scahill found that parent training can be effective for reducing disruptive behaviors in kids who also have tics. Not surprising. Yes?
That being that some kids are not bothered by their tics, either because they're of a certain age or the tics just aren't interfering enough and may not be motivated to participate in CBIT and therefore may not need it. And it's okay to say, come back later if it becomes more bothersome, because the burden is really on the participant to use and practice the strategies that they're learning. But I will have parents come in and say, I'm happy to provide. Matt mentioned, there's the habit reversal piece that's on the participant to use those strategies, but there's a host of other interventions that are taught to parents and family members, and parents could come in and participate to learn what we call the functional interventions, which is managing the environment, creating this tic-neutral environment. So whether the child is refusing because the tics aren't interfering or refusing because they're being oppositional, you could work with a parent or a family member to a point, or just focus on the comorbidities, doing the parent training or other sorts of treatments, and sometimes may not need the HRT at all.
Yeah, I think that there are plenty of kids whose dentists have told them, they should floss every night and brush their teeth, and it turns out without parental involvement that may not happen. Yeah, right? Especially in, primarily boys who have, sometimes attention problems and the like. And so I think what we're learning now is we really, really do, to Dr. Bennett's point, we really do need to get parental involvement to really maximize the outcomes. and you know, things like BTPT, other forms of parent management training, are really just trying to help parents to effectively parent in an inordinately challenging parental situation. Good segue.
So I will be talking about parent management training as part of my portion of the talk. Where is it? So Matt, I think you stole my thunder a little bit. So I will be talking about special considerations for children and adolescents. And primarily what I'm going to talk about is not necessarily the clinical trial aspects, as well as what I tend to do clinically. So I'm Adam Morris. I'm a clinical psychologist here at Albany Medical Center. I work probably a quarter to 50% of my time with kids who have Tourette's. But I also spend a good deal of my time working with comorbid conditions as well. So I'm going to get into a little bit of the weeds in terms of what we do clinically. I want to start by saying I have nothing to disclose, but I hope to someday. So one of the things I think that I tend to focus on and really instill in parents is that we're trying to increase behaviors in kids when we do CBIT. Predominantly competing responses, and much like brushing your teeth, flossing your teeth, some kids aren't motivated to do that. And part of this is helping parents to recognize that they're a part of their context, their environmental context. But there are things that are in their control and things that are outside of their control. But helping parents to recognize the things that they have control over, that they have influence on, and helping them to understand how those influence tics and the presentation of tics is part of what we do in parent management training. One thing that I tend to do clinically is oftentimes parents will come in and they don't know what to do. They're referred to meet with me, to consult with me about what to do in terms of behavior management or management of tics. And setting the expectation at the front of parents, you're going to be included in this. I want to meet with everybody. I want everybody to be a part of this. I'm not just going to meet with your son or your daughter, that I'm going to meet with everybody. And that's a part of the treatment and making that a part of the discussion right from the very beginning. So it's often complicated, and I mentioned this earlier, of the involuntary nature of tics combined with this idea of, is this in their child's control? Can they manage this? It's a very complicated discussion to have. We know there are internal variables, so anxiety, for example, as well as external variables that influence tic expression. And so we oftentimes will work with parents on what are these external variables that they have control over that they can help shape their child's environment to help them be more successful. As well as helping the child specifically with internal variables, like anxiety, that may precede the expression of tics. Within this also, as everyone has mentioned, there are often co-occurring disruptive behavior problems. And so oftentimes the discussion will come up of what do we target first? That's a commonly reoccurring theme. Do we target the tics or do we target the disruptive behaviors? And oftentimes it's looking at what is functionally impairing that child the most. And oftentimes it is the disruptive behavior problems. And so helping a parent get more control over the environment and understand the presentation of disruptive behaviors can eventually lead to better tic management. So one of the things to recognize is that as part of, and this has been mentioned throughout the lecture series here, that caregivers and parents are trying the best they can with what they have. And oftentimes they're coming to me in terms of clinically to what can I do to help? And part of this is helping parents in a non-judgmental way, and helping sort of push through some of the guilt that parents may feel to understand that they are part of the solution, and not to get into a blame game. That often comes, am I to blame? I'm their parent. And it's helping everybody recognize that they're a part of helping this child to be successful. So I tend to be very, very focused on the positive aspects, instilling a sense of hope in parents that there is something that they can do to help, but also recognizing that there are things that parents may do that may not help as much, that may influence and impact a child's behavior, in terms of things that parents may do that may incidentally reinforce the expression of tics. So we've talked about if a child has tics and they don't have to do their homework, right, being an example. Or they're expected to do the dishes and they have an exacerbation in tics, so the dishes get done. Or other commonly occurring things where the parent may not understand or recognize that they're reinforcing a certain behavior, not by, they're not thinking, I'm gonna do the dishes because that's going to increase tic severity, but helping them recognize and become aware of how their behavior influences their child. The other piece is helping caregivers recognize the role anxiety plays. Anxiety is an internalizing disorder. And oftentimes as parents and even as providers, we may not recognize when our children are anxious. We may see externally that they're displaying behaviors, but we may not know exactly what's happening. And so what may happen is that parents may respond to certain cues that their child's giving them. Oftentimes avoidance becomes part of this, that there are situations that evoke a sense of anxiety and they feel distress, so parents are parents, right? That's they don't want to see their children in distress. No parent wants that. And so they're doing things to help their child, but may inadvertently reinforce avoidance, which may then, long term, increase the likelihood that tics may present themselves in those situations that kids are avoiding in the first place. I know that's long and confusing. So if you have questions throughout this, please feel free to interrupt. But it's really helping them understand how anxiety plays a role, how their behavior plays a role, and it's oftentimes helping on a case-by-case basis to help families recognize these things. So as I have alluded to, one of the main goals of parent management training is to help parents understand that their attention matters a lot. What parents pay attention to, kids will repeat again. I have a 3-year-old, and every now and then he'll say something, and I'll laugh, and he'll say it again, and again, and again, because that got a nice response. He felt really good. I said something and Dad laughed, right? I gave attention. Now, if that's something that's cute, and I want to see it over and over again, I may laugh every time. But if that's something that I may want to help him reduce, what I attend to may be an important part of that mix. The other piece of this is that when there are those comorbid behavioral difficulties, that focusing on compliance versus non-compliance, often parents put all of their energy in the non-compliance realm. What are they not doing? And often don't see, and oftentimes this is hard when kids are non-compliant, right? We want to look at what are called approximations. Are they getting close to compliance? Are they showing us a little bit, right, of that behavior? Because we want that to go up, right? And this also pertains to competing responses. Right? They're learning a new behavior. They're learning something that's going to compete with the tics. And oftentimes they may not get it the first time, or the second time, or the third time, or the fourth time, or the fifth time, but they're getting close. And oftentimes with behavioral therapy, it's this belief that, we collect data and we're kind of mean and we don't really express our emotions, that we're just, okay, you did it, didn't do it, did it, didn't do it. But clinically, oftentimes I tend to be very positive, to focus on, you got close, keep going. Oh, that was really good, really good. And helping parents to recognize that kids are also trying the best they can with what they have. That's another strong piece of this, is helping them to understand that their attention matters and that they can help their kids increase some of these behaviors as well. The other piece that I'll get to in a little bit more extensively is helping parents understand behaviors in context, understanding antecedents and consequences. So antecedents is just a long term to say triggers, right? What are the things in the environment that may lead to an exacerbation in the presentation of tics? What may be antecedents or things in the environment that increase the likelihood of any behavior occurring? And that they may play a role in the antecedents. Parents may play a role, families may play a role, siblings may play a role, as well as the consequences, what comes after the behavior is displayed. And so the goal with parent management training is to help parents, really, the approach I tend to take is educational. I want you to know what these aspects are, right? What is antecedent management? What is the management of consequences? And helping parents to get better stimulus control. Can they help serve as a cue for tic management, behavior management? And so a lot of it is helping being a guide for parents. So within this, there are specific skills that we're constantly talking about with parents. And I tend to sit on the idea of attention a lot. Paying attention to specific behaviors you want to see more of. Make as much out of a positive behavior as you do a negative. Right? If you're yelling at them for not doing the dishes, that's attention. The brain doesn't have a switch that says that's positive, that's negative, especially with kids. They can learn that attention is gotten in other means. Within that, there's also this idea of differential reinforcement. So you're reinforcing a behavior you want to see more of and paying less attention to behaviors you want to see less of. So that's what we call planned ignoring, because it's planned. You're not just ignoring your children. Right? You're ignoring specific behaviors that they may display while simultaneously paying attention to the ones you want to see more of. And you do this through labeled praise. Good job is not labeled praise, unless it's good job doing X, good job doing Y, great job. I'm thinking of all the wonderful children that were up here talking about their experiences. Great job standing in front of a group of people that you may or may not have met before and staying there and just experiencing it. Wonderful job. That's hard. That's hard. So the whole idea is catch your child being good, catching your child doing the things that you want to see happen. It's been alluded to about functional interventions, and I wanted to briefly talk about this. Because this is really helping parents to recognize the antecedents, or the things that come before tics, that increase or decrease the likelihood that they'll happen. And so this is done through a functional assessment. Looking at events, behaviors, any circumstances that exacerbate or maintain tics. And this can be any number of things. A functional assessment is not to say it will definitely be this, it will definitely be that, it will definitely be this. It's different for every child. There's different circumstances that occur for every different child. One of the other things that was alluded to earlier was this idea of a tic-neutral environment. So when you're helping children manage tics, you're teaching them competing responses, you're teaching them to become aware of premonitory urges. And that can be really hard too, right? That's a lot of effort. And so you may balance between, training and helping a child to manage their tics, but also creating an environment where they don't have to work as hard, right? And minimizing those situations as much as is possible, while also alleviating some of those behaviors that parents may engage in or that others may engage in that increase the likelihood of a tic presenting itself. One thing that I often talk with parents about a lot is this idea of high-risk situations, right? So getting rid of all tics is not something that we set as an expectation, right? To say the goal is none forever, right? The goal is to learn how to manage them, right? And part of it may be learning high-risk situations that are more likely to lead to tics, and helping a child learn coping strategies for those situations. So one part of this is often pulling in the literature on exposure therapy as part of this, right? If our understanding is that there's quite a bit of comorbid anxiety, exposure becomes a part of the paradigm, right? Helping kids to be put in situations that are high risk while also practicing managing their tics. So if this is around people, right, maybe part of the intervention is working with putting a child in a situation where there are people, not an overwhelming situation, but a situation where there are enough people that they're saying, oftentimes what we do is we have children rate their anxiety on a 0 to 10 scale, right? Where are you? Right? Check in with them, right? If they're a 10 out of 10, that's not where you want to start, right? You want to start for maybe a 5, right? I'm a little uncomfortable, right? Okay, good, we're a little uncomfortable, let's work on managing your tics in this situation. And then branch into or fade into a more densely social situation. Another part of this is also educating teachers, peers, family members in ways that they can also reinforce behavior, so tic management in a school setting. Another part of this is structure, particularly when you have kids with disruptive behavior problems, ADHD, predictability. Predictability is always helpful. We always want predictability. We want to know when things are going to happen and how they're going to go, but we can't. But we can get close. And we do that through helping parents develop routines. So bedtime routines, morning routines. The idea is that if a child is exhausted, they may not be able to manage their tics as well. So focusing on a bedtime routine where they're better regulated in terms of their sleep habits then has a connection to better management with tics the following day. So regular sleep, regular exercise, self-care, all of these activities of daily living, focusing on those and helping parents to increase those as much as they are addressing tics themselves. Being clear with behavioral expectations. So Dr. Speck talked about sort of these verbally mediated rules. Well, that also pertains to rules around the house as well, in terms of what are the expectations for behavior? What am I, as a parent, looking for? As well as setting up natural rewards consequences. So what are the things that this child really, really enjoys, that we can reward them for expressing certain behaviors? So with creating a daily schedule, we often focus on your current schedule and an ideal schedule, sort of an unrealistic schedule, but if you had control over everything, right? If you had control over money, time, all of those variables, what would be the ideal? And is there some happy middle point with a regular schedule? Looking at focusing on what behaviors you want parents to reinforce, a logical sequence throughout the day. Also, which behaviors that they engage in are going to get rewarded and at what rate. Oftentimes schools struggle with this where they say, you can't make it through the whole day. I know, we all know. We need to reinforce a behavior earlier on. Let's maybe build a reinforcer at lunchtime or a reinforcer at 10 a.m. and build up to a full day. And also establishing times when a parent is allowed to check in. This is oftentimes what we see with older adolescents, where it's, Mom, Dad, please don't talk to me anymore, right? Please don't say anything, right? And so part of it, you may, especially with older adolescents, set up a contract. This is what I expect you to do, son or daughter. Mom or Dad, this is what I expect you to do. And I allow them to call their parents out if they don't meet the contract, right? We agreed that on Monday at 4 p.m. you were allowed to check in with me. And you checked in with me at 3, right? So some of this is sort of negotiation around that check-in point too. Another part of parent management is helping parents to recognize their own internal triggers, their own anxiety, and how that influences their children. How their own ADHD symptoms may affect their children. If they have tics or Tourette's themselves, how that may influence their children. One of the things too is often telling parents it's okay if your kids are struggling. It's okay. It is okay. There are ways that, struggling can lead to mastery, right? I forget the football coach that said if you're not failing, you're not working hard enough, right? So mistakes are part of the game, right? And helping parents to recognize that they don't have to get this right the first time or the second time or the third time, that it's really helping them to become masters through mistakes. And last but not least, encouraging parents to take care of themselves. I use the old analogy, if you're on a plane, they tell you put your mask on before you put your child's on for a reason. If you aren't getting oxygen, you won't be able to help your child. And so taking care of your own needs is often a very big part of this, right? If we're helping kids to learn coping skills or management skills, we're models for our children. So what we show them through our behavior has an effect on them long term. So I'm going to turn this over to Dr. Sullivan now.
Thank you very much. Great presentation. Can everyone hear me in the back? All right, thank you for the nods. I appreciate it. I am Dr. Paul Sullivan. I'm a child psychologist from Weill Cornell New York Presbyterian. I just want to thank everyone in here for coming today. Parents, the children, providers. This is one of those special moments where we really need to appreciate this because everyone in this room is getting the education that they need to move forward and help educate the individuals around us so we can help these individuals in this population. Disclosures, I have none, again, unfortunately. So another thank you to Diana Scheinman for allowing me to use this data today, the TAA TS Impact Survey from 2018. So this survey was distributed through social media, through email, and also distributed to the Centers of Excellence. And so the individuals who were given this survey were roughly 281 adults, 623 children. Important to note that the caregiver did the survey on behalf of the child, and 40 people who did not have TS or tic disorder. And what was found is quite sobering, as Dr. Bennett said. 63% of children said they felt discriminated against, either bullied, removed from class, removed from extracurricular activities, and also felt like they were being treated unfairly. You may wonder what the national average is. According to StopBullying.gov, the national average of children and adolescents who feel bullied between the grades of 6 and 12 is roughly 20%. So it's quite staggering to compare those two numbers. In case you were wondering about the adult population, that is around the 80%. Dovetailing off of this is that 32% of the children reported considering suicide or participating in self-harming behavior. Again, compared to the adult counterparts who had the survey done, that was around 51%. So as mental health providers, as providers in this room, we always need to make sure that we assess for risk in any population who comes through our door. Our assessment begins as soon as they walk through the door, taking their mental status and asking them about risk factors as well. And for the children who were surveyed, 83% of them felt that the Tourette's negatively impacted their experience at school. And just to divide this out a little bit more, Again, thank you, Diane. So roughly, for these kids, under 10% were held back a grade. I'm going to get into that a little bit more scientifically with some data. More than 40% felt that they were discriminated against by teachers, and also 40% roughly were forced to miss school or have extended absences due to their Tourette's. In this other category here, that encompasses bullying. That also encompasses the children and adolescents who were surveyed, their caregivers reporting that their teachers didn't quite understand what Tourette syndrome was. And so again, as we heard from our lovely panel earlier, teachers just need education, or schools need education. We need to be advocates for our children and adolescents. One thing, rather than waiting for the teachers to come to us, we also need to make the initiative to share our education and share what we know.
Anecdotally, we tend to see our kids really struggle in middle school, which is kind of the perfect storm, both in terms of age and in terms of the setup of the school and of the parent-teacher-school relationship at a point at which the schools don't want parents involved. And even with the model, when you're talking about for doing functionally, you need teachers involved. Right. How is that realistically?
That's a great question. I'm going to try to answer it as concisely as I can. I think collaboration, we have the power as professionals in this room of reaching out to teachers, whether that's through a letter, whether that's through a phone call. I know the lovely psychologists I work with at Weill Cornell, the first thing they get is the consent to release to talk to the teachers. And so making that relationship, forming that bridge, bringing the lovely materials from TAA into our teachers so they know what symptoms actually look like, because it can be confusing what teachers maybe view as oppositional behavior. We know that it's not under our kids' controls when they have to engage in their tics. I don't know if you want to add anything else.
I think it's if you ask it once, ask it again and again and again. It's sort of an ongoing advocacy with schools, unfortunately, and helping to sort of make teachers aware of it can be an ongoing battle, because they change teachers each year. So you may have one teacher that does a wonderful job, and then the next year a teacher that doesn't. And that can be, I think, a very tricky thing to keep the school with a consistency. And that's, I think, part of having realistic expectations for children as well, I think goes into part of that, right? To say that there may be times where there are things that are outside of our control that we have to be aware of doesn't mean that we can't continue to advocate and continue to stand up to address them, but also be aware that that is part of unfortunately, the circumstances that kids are placed in at times.
And just another point, we also know that kids see multiple teachers during the course of the day. So it's not just one teacher that we're working with. We're working with maybe up to 7 teachers, and then we think about coaches. And it's unfortunate to say not all of them are going to be the best advocates, but it's identifying those ones that are going to be those advocates for our kids. So looking into more of the educational impact of TS, so again, there was made mention of earlier in regards to comorbidity and learning disorders. Sometimes it's maybe a horrible metaphor. I like to think about kids as pieces of cheese. And we've all seen that really nice American cheese slice from Kraft. It's very whole, and nothing really gets by it. But when we think about the idea of kids who have tics in class, they're more Swiss cheese in that way. And what I mean by that is, even though they're getting the information from their teachers, there's holes there, and they're missing some foundational learning skills in which they need, because they're either distracted internally by the premonitory urges, or they're engaging in their tics while in class. So we need to make sure that we're also ruling that out when we're seeing our kids come through our door, to ask them about any sort of comorbid learning difficulties. Some examples here from Sue Connors in regards to how this may make it difficult to read. It may be more difficult for a child to engage in their homework through writing because they have an arm jerk tic that they really can't complete and they go off the rail. Difficulty concentrating, maybe difficulty seeing the board because they have to turn their head. And also, when you think about the idea of vocal tics, just interacting with their peers, interacting with their teachers might be quite difficult for them. And so we always need to check in with them and make sure that we're ruling out any comorbid learning disorders as well. Continuing on, so this is from the National Survey of Children's Health from 2007-2008, and also 2011-2012. So it's quite a large catchment of children, around 130,000, on actually a very small percent who are identified with TS. And so Unfortunately, within this study, they only inquired about IEPs, they didn't inquire about 504s, but they found that kids with TS were more likely to have IEPs and also have their parents contacted about school problems. Also more likely to have kids who had difficulties in homework. So again, we think about our kids who go through the course of the day, but also their parents, the stress that causes them as well. So we think about the idea of working with the system and making sure that everyone within that system feels supported. And also for the kids, again, the comorbidities associated with them. For kids who had severe TS and also comorbid condition, whether it be OCD, whether it be ADHD, they're actually 40% more likely to repeat a grade as well. And thinking about our kids, not only in the classroom, but also we think about the idea of the antecedents before the triggers. Sleep is so important, no matter what age you are, making sure they get a good night's sleep. And so within this similar study, they looked at caregivers, and caregiver reported their child's sleep. And surprisingly, what was found is that kids with TS had almost a night and a half worse of sufficient sleep than normal controls. So we think about the idea is sometimes a child goes to lay down for bed, but they have their tics that engage them, or maybe some of their comorbid conditions that get in the way of them getting a good night's sleep. So again, for our lovely pediatricians, nurse practitioners, we want to assess sleep to make sure our kids are getting a good night's sleep. Because again, sleep can also exacerbate tics and just make school that much more difficult for our kids as well. And interestingly, what they found is that early adolescent females with more moderate to severe tics had fewer nights of sufficient sleep than males. Interesting. So looking more about how this affects self-concept and self-esteem. When we think about the idea of self-esteem, that's how kids view their self-worth, whereas more self-concept is how do I view myself also in my social life as well. And so this is a review of 10 studies. And actually, the results kind of varied. A famous maybe therapist line is it depends. But we looked at the idea of lower self-concept and self-esteem. There were some mixed results there. Lower self-esteem was actually found in younger children with chronic tic disorders. As we've been talking about today, if you walk away with one thing, it's the idea of comorbidity with this population, is that those individuals with comorbidity actually had worse self-concept and worse self-esteem than comparatively speaking to those kids who just had purely TS symptoms. Social functioning was highly impacted with those individuals with chronic tic disorders or comorbid conditions. And what they found was a trend actually for parent reaction to the diagnosis and also parenting styles, a strong contributor as a protective factor to make sure that kids' self-esteem didn't dip. So as we can see, the lovely parents who are here are accepting and embracing and supporting their kids. And we want to think how we can psychoeducate our parents so we come through the doors to invoke that in them, because we know that parental support and reactions are extremely important. And when we think about the idea on the flip side, what are risk factors? Poor self-efficacy, and that's why thankfully we have treatments like CBIT. We have cognitive behavioral therapy, because what do those two treatments do? They bring up the self-control that the kids feel, the mastery experiences in which they need to feel that they can reduce their tics and also function, whether it be in school, whether it be at home, whether it be just doing sports as well. And another risk factor was just parental acceptance and just those peer relationship difficulties as well. 1 minute? All right. So I would be brief with the rest of my slides. So quality of life. Unsurprisingly so, the kids who have more comorbidities have worse quality of life, comparatively speaking. If anyone would like my slides, just find me after. I'll be more than happy to email them to you. So the takeaways, what can we do as parents, as professionals, as policymakers? We choose to assess all the kids who come through our door. And just like they say in the, not the MBTA, that's Boston, but on the subway system, if you see something, say something. If you're concerned about it, go to a professional, talk to them, and also professionals, make sure that you believe what the parents are saying. Trust their reports, trust the kids' reports when they're telling you that they're struggling with these things. And education is extremely important. Tourette.org, finding those advocates. DASA, the Office of Civil Rights, as well, can be great advocates for our kids, and also requesting that our kids get 504s and IEPs for assessments as well. And speaking on a larger scale, we need greater mental health initiatives by our policymakers. We need more funding to help these kids out, to get into the schools, to make those relationships so that we can help educate and help support these kids where they need it the most. Thank you very much, everyone.
one more talk, so why don't we have our last talk? And then we'll have some time for questions at the end. That's okay. All right, so Dr. Morrison is going to start us off. Just, this is us.
All right, as this is getting loaded up here, so this is the last lecture, the finale, bringing in the relievers to finish it off. But really, the main idea is to take all the concepts and keys that we laid out today and really try to put them and synthesize them all together in terms of where do patients go with Tourette syndrome and how do they go on to life? Because a lot of times, can I see a raise of hands, how many of you providers care for adults with Tourette's above the age of 21? Right, so you can still have a really good impact in regards to how these patients are going to function later on in life in trying to address all the different needs that the patients have. So, yeah, nothing to disclose.
I have a few. I'm on the medical advisory board of the TAA. I have received grant funding from them and do sometimes get paid to speak, but not here. And I receive royalties from Up to Date for a piece on anxiety disorders.
All right, so I'm not going to go through the objectives here, but basically I'm really going to focus on how we can try to get the unmet needs in children and adolescents with tics and make sure that we can launch them into adulthood and make them successful. Because the bottom line that anyone wants for their children is to be independent and to be functional. And so those are the main things that we really want to try to address as physicians going into adulthood. So we've gone through the general characteristics. I don't need to review all this, but what I really want you to see is the bottom right-hand corner, and these are the main themes that we brought up today, is that the tics typically improve over time, and it's the psychiatric comorbidities that tend to persist. And also, it's the psychiatric comorbidities that tend to be the most functionally impairing for adults with Tourette syndrome. Overall, I'd say about 25% of my medical management in adult patients with Tourette's is on their actual tic disorder. 75% or more, I'm making medical management decisions based on their anxiety, their depression, OCD. Okay, so again, tics tend to improve and their psychiatric comorbidities are what tend to persist. And this is just a good graphic representation of this, looking at the peak onset of a lot of these different associated conditions in tics, how the tics get better, but then just seeing how the different comorbidities tend to linger, and that's what we absolutely need to keep addressing day in and day out with our patients.
And this slide hammers that home as well. So you can see the prevalence of the major anxiety disorders and mood disorders in the young adult 18 to 29-year-old cohort is equivalent or more than the total lifetime prevalence. So we know anxiety disorders emerge very early in life. Separation anxiety and phobias start young. Social anxiety and panic disorder later in adolescence. Depression, bipolar disorder later in adolescence and young adulthood. We also see in late adolescence and early adulthood the emergence of eating disorders, psychotic disorders. So this is a stage of life there's a lot of risk and vulnerability for mental illness, while at the same time the developmental tasks and milestones of young adulthood are enormous. And pediatricians, I have a 3-month-old and a 3-year-old, so I'm constantly reporting on their developmental milestones. But as we grow older in adolescence and in young adulthood, we don't talk about developmental milestones as frequently or as commonly. But if we look at this list, emotional independence, self-identity, behavioral independence, completion of ADLs, assertiveness, task completion, managing money, making and keeping relationships, taking care of yourself, accepting your sexual identity, romantic relationships, accepting your cultural affiliation or choosing your cultural or religious affiliations, long-term vocational goals, education requirements, financial independence. I always say when I give this talk, I won't take a poll of the audience to see where we all fall on this list because it's really overwhelming. So for young people who are finding their way to independent adulthood at the same time that there's this convergence of psychiatric risk, there's a lot going on. So, but we can boil this down into kind of these 4 broad areas of independence, identity formation, acceptance of responsibility, and good socialization. And this is, again, borrowed from the anxiety literature, and Dr. Specht and I co-direct on our campus a program for young adults with anxiety that, where we see we see escape and avoidance with anxiety disorders all the time, but I think this is true for stress and for young people with tics or depression, that when you find yourself in a situation that feels stressful or overwhelming, and it was said earlier, our instinct as people is to get out of that situation. When your fight or flight system kicks in, it's just that. It's fight or flight. You want to get out of there. So that's totally understandable. Or do whatever you can to make it better, whether that's a compulsion or some other unhelpful behavior. Unfortunately, as those patterns persist and as the avoidance persists and grows and expands, it takes young people out of the situations that they really need to be in to develop and to meet those milestones. So young people growing up with anxiety or tics or mood disorders or other conditions may fall off that developmental trajectory and be on a different path from their peers, particularly when there's a lot of this escape and avoidance that's happening. And what also happens is when you avoid or escape, you then remember that situation at the height of stress. You miss that this happens, that if you don't avoid, things do tend to get better. And that is this sort of riding the wave, whether that's of our anxiety, of our stress, of a premonitory urge, that these things don't last forever. It's really uncomfortable, but if we wait around long enough, it will get better. That's not always comforting to hear, but it prevents us from learning how to cope or how to calm ourselves. It sort of robs one of the experience of mastery, and that escape feels really good because you have this immediate relief at the time of escape, and that's very reinforcing. But it then prevents sort of the formation of these really important areas. So what skills do young people need for their development and their mastery? Well, problem-solving skills, good social skills, emotion regulation skills, realistic thinking skills, flexible thinking skills, perspective taking, anxiety management, stress management, time management. Again, I won't take a poll at where we all fall with our skills, but really opportunities to learn and to make mistakes. So repeating what was said earlier, we need to experience stress and adversity in life so we can learn how to manage it effectively. So whether these skills are learned at home or they're learned at school or they're learned in therapy, these are the sorts of skills we're hoping young people will acquire. And we need family support, absolutely, and scaffolding, but not overprotection, because that will prevent the acquisition of these skills. So, and this is, I think, repetitive, so I won't spend too much time on this, but parents, our instinct is to protect, and so well-intentioned accommodation can unfortunately start to make things worse, and misunderstanding can lead to blame and anger and conflict that's not helpful. There becomes this sort of shared anxious anticipation of upcoming events, that each next thing is too big to fail. So there's more protection and more accommodation as we move through development. There's middle school, high school, college. Each thing is just bigger than the last. But the overprotection and avoidance leads to this lack of learning and lack of developing the capacity to regulate. So the challenge is knowing when to push and when to protect, and I certainly do not have the magic formula for that, but knowing that there has to be a little bit of each. And this has been said, but parents and families need support. So we're borrowing, this is a little bit repetitive, but young people growing up with TS, just to repeat these sort of developmental issues that are interfering with independence and autonomy might be dependence on parents, therapists, doctors, dependence on medication or school modifications get in the way. When we're looking at personal responsibility and accountability, there may be some consequences there from ADHD, OCD, anxiety, mood symptoms, or learning difficulties. When we're striving towards personal identity, values, peer group sexuality, again, we may see a different maturation trajectory, school isolation or bullying, medication side effects may interfere here. And when we're looking at self-competence and body image and skills and performance, again, we may see some interference from medication side effects, ADHD, OCD, or executive function. So we use this, there's this term called failure to launch that gets thrown around a lot for young adults. And so we borrowed this metaphor from Dr. Budman and our colleague Heather Adams of a rocket. And what do we need to do for a successful launch? So the fueling and the preparation for launch requires, what might get in the way is difficulties with executive function, co-occurring conditions, emotional energy, those limitations to motivation and initiative. What challenges liftoff might be rigid style, OCD, anxiety, disorganization, impulsivity, distractibility, academic delays, poor time management. What interferes with the rocket itself may be this need to modify or change the path you're on, or finding that balance. We need navigational skills to stay on course. Those may be challenged by inadequate educational supports or vocational supports. If family members are under stress themselves, that impacts the amount of support that they can provide. And refueling may get interrupted when managing tics or co-occurring conditions. Medication side effects play a role here, and that all drains a lot of energy that we need to achieve our goals. So how do we help? Building mastery of daily life skills. Again, we need mental, physical, emotional energy. Shedding old habits, confronting fears, setting realistic goals, and knowing you may need to try again and again to get there. These things may be college, it may be joining the workforce, it may just be trying to live on your own, it may just be making dinner for yourself. So wherever you're at, trying to set those small goals. For the rocket, clarifying what your own individual values, priorities, and goals are for young people is important. Making those goals attainable and creating a map and a pathway to meet those goals. Learning and practicing new skills in order to achieve your goals, and finding sort of the structures and supports that will help you get there, and so that you can sustain motivation and build that internal momentum that helps us develop resiliency to persevere through ups and downs. So I'll turn this back to you.
All right, so just going to close out with a few different slides, again, related to the physician aspect about children and adolescents as they get into adulthood. And again, I kind of want to just actually get to the next slide and go through actually a couple questions and scenarios that I get as an adult neurologist in movement disorders in regards to transitioning these kids. Do they even need to see a doctor for TS? Again, as what we've mentioned before, tics tend to improve over time. So if their tics aren't bothersome to them or they're very stable, then they don't necessarily need a specialist like a psychiatrist or a neurologist to manage their tics. The primary care doctor is very adequate at doing that and can still screen and ask about the different symptoms related to anxiety and depression, compared to other individuals that are having active ongoing anxiety, depression, OCD, difficulty with tics. Then it makes a lot of sense to refer to a subspecialty provider in neurology or psychiatry. When should we switch? Complicated question. What I would say is you really want to make sure there's adequate time in regards to the patient being able to establish care with a new provider and having follow-up. The last thing you want to do is have someone see you at 18, they go away to college, and you send the referral, and then you're trying to find a time when they get back on their school break to see the new person, and then they can't follow up. And so a lot of times I tend to see them after the age of 21. The pediatrician or the pediatric subspecialist tends to provide until age 21. But again, there's overlap, and some may not go to college and they're around working, and then I'm able to transition care. But you really want to do it in a time where it's not going to be stressful for the patient. What kind of provider do I see? I already mentioned that. It depends on what their needs are. How often do I see a provider as an adult? I usually say my patients see me about once a year, depending upon how active their comorbidities are. Sometimes I tend to see them every 3 to 6 months, but in general, I tend to see patients once every year. And every time I see them, I address not only the tics, but how their associated symptoms are and the medications that they're taking. Some other hot topics that I get as an adult neurologist. Kids are developing. They're getting curious. They want to try new things. They're getting of age to drink alcohol. So Dr. Morrison, is alcohol going to affect my tics? Is it going to affect my development? How about the medications I'm on? Can I drink with guanfacine or Topamax? And, the bottom line that I always educate my patients, you have to use good judgments in that, medications and the interaction with alcohol is different for everyone. I wouldn't say it's an absolute contraindication. There are certain medications like metronidazole or things like that that can cause a disulfide reaction, but obviously you want to limit that. you want to educate them that everyone is very different in regards to how they react to the medication. I don't endorse it by any means, because again, you have to worry about substance, and using to treat some of the symptoms that they're having of anxiety or the tics, so you really got to be careful, but I get this very, very commonly. Next is medical marijuana indicated. Doc, I smoke weed and, my tics are so much better. Why can't I get medical marijuana? I'm going to go into some of the studies that we have that clearly don't show really a role for it right now, but it is a very common question that I get into adulthood, and you also got to understand what symptoms are they treating when they choose to smoke marijuana. Are my children going to have Tourette's? We've spent a lot of time on this as well. It's very complicated. My patients are thinking about having relationships, having families, having children. Are they going to have tics? If I do, or if I have tics, are they going to have as severe or not as severe? And so that's a very difficult question, right? It's not like Huntington's disease where it's the Huntington gene on chromosome 4 of the CHE repeats that clearly causes the disease. There's some families with a histidine maybe receptor or some genetic type of mutation, but it's complex, as we talked about. And so I just say, they're probably at a little bit higher risk since you have tics, but again, we deal with it when we come in. I don't think that's a reason why they couldn't potentially have children. And again, if someone has Parkinson's disease, their father, they're probably a little bit at higher risk, so you just want to educate as best as they can. If you want them to see a genetic counselor, that's perfectly fine, but usually that's sufficient. And the last is, of course, can I sustain meaningful employment? A lot of times we're looking at kids and their success in school, but where do these kids go after? Do they hold jobs? Are they able to maintain jobs? Are they able to live on their own? And so that's a common question, especially with the co-occurring conditions that tend to be the most disruptive. So we've gone through this. I'm not going to go through. I just wanted to give some anecdotal points as an adult movement disorder specialist, what I do, because a lot of times other co-occurring conditions besides the ones we talked about, hypertension, migraine, seizure disorder. And so if you're looking to treat because of how impactful they are, then you try to do two birds, one stone. If someone has really bad migraines and tics, maybe I'll use Topamax. If someone has hypertension, maybe I'll use guanfacine to help with tics and hypertension. I would say rarely am I ever prescribing tetrabenazine. That is a VMAT2 inhibitor, the dopamine depleter, and it's a big gun, increase the risk of worsening depression and suicidality. And so I would say that it's rarely ever the case that I'm continuing the medication, because tics can tend to get better. So there's really no need in certain circumstances. Again, there are those individual cases where tics are very refractory that I'm actually prescribing a VMAT2 inhibitor such as tetrabenazine. Again, behavioral strategy, CBIT, that is still my first line even in adults. We have both an occupational therapist as well as a psychologist that does CBIT. And based upon what their comorbidities are, if I see there's a lot of anxiety and OCD too, maybe I'll funnel them towards a psychologist. If it's really kind of just the tics, then we'll do the occupational therapist. But really what it comes down to is access to care. I mean, honestly, that's really when you have people traveling 3 hours to you and seeing you, say, well, where can I do CBIT? At home, it's really hard for me to give them answers, and that's where maybe Tic Helper and online modules are becoming very helpful. So one of the questions earlier is what's on the horizon? What are the different medications that are being studied right now to look at the treatment of tics in both adults and children? So what I'd say, it's been kind of a long time since we've really developed a novel type of medication that's helped with the treatment of tics. A lot of the new studies are looking at variations of the VMAT2 inhibitors. That's deutetrabenazine, which is Austedo, and valbenazine, which is Ingrezza. Basically, deutetrabenazine has deuterium. It's a heavier hydrogen atom. So as a result, it reduces the metabolism and slows it down so that you can reduce the peak side effects of somnolence or fatigue that we sometimes see in patients on tetrabenazine. It is very similar in regards to its structure, so it still carries the black box warning. And right now, it is only approved for chorea and Huntington's disease and tardive dyskinesia in adults. And Joe Jankovic did a phase 1b study down at Baylor looking at deutetrabenazine that showed some mild positive results. So actually at the U of R, we are looking to start enrolling patients between 6 to 16 in a phase 2 trial for deutetrabenazine, the treatment of tics. The next is valbenazine. So again, a very similar structure to tetrabenazine. This is actually dosed once a day. Tetrabenazine is something that's either 2 to 3 times a day, and that can be very burdensome for the patient. So if we can get something that's once a day, a little bit longer acting, and can reduce those side effects, that would be a little bit more ideal. In addition, interestingly, it's right now only approved for the treatment of tardive dyskinesia, and in that clinical trial, it did not show worsening of the different mood disorders, which of course is one of the issues that we think about in regards to using tetrabenazine, worsening underlying depression and potential suicidality. So that's something, again, to keep in mind. We honestly just need to study it a lot more to see if it truly pans out like that. There was a recent study, I believe it's a phase 2 study of 126 patients in T-Forward that was unfortunately a negative study for valbenazine, but again, I think we just need a little bit more data going forward in regards to the use of these different VMAT2 inhibitors. Any questions on them before I get to the hot topic? Medical marijuana, right? So, you know, I really want you guys to understand is that I'm not against it by any means. As a physician, it's really about objective evidence. What do we have to provide evidence to our patients that these are effective treatments? The AAN, American Academy of Neurology, just recently published a draft of the updated treatment guidelines. It hasn't been finalized yet, but it was open to providers to comment on. And when they talked about medical marijuana, there were only 2 studies that they referenced, and they are from 2002 and 2003. Are they not that great? And I'm going to go into why that is the case. The first study, randomized, double-blinded, okay. Crossover study of only 12 patients, okay, so that's not a lot of patients, and these are adults, okay. It was a single dose of THC as the dose is there. The tick severity was rated over a single day. There was a washout of 4 weeks, and then they got the other treatment for a single day. Ticks can vary all the time, day to day. So that's really not a good way to assess it. And the way that we always assess, and a lot of these studies, I don't know if people notice, it's the Yale Global Tick Severity Scale. That is the objective measure, that is the endpoint at a lot of these trials in regards to improvement in ticks. And so they saw that there was no significant difference between the 2 treatment groups when they did this crossover study. So again, not very good. And it was 1 day, separated by 4 weeks. Next was a year later. Okay, another randomized, double-blinded, placebo, 24 patients, so double the amount. It was for 6 weeks, and they had 6 clinical visits. It was just 1 dose at 10 milligrams. Interestingly, 7 patients dropped out of this study, 1 due to side effects, 6 for other reasons. And no significant difference was seen between the THC and the placebo group. Again, based upon the outcome measure, the Yale Global Tick Severity Scale. Yes, it's important to understand the subjective improvement in patient questionnaires that people fill out, but we need objective evidence and rater assessments in order to really determine, is there a clear difference between the active ingredient and the placebo? And so based upon this, these are 3 different comments that I've cut and pasted from the draft. Again, it's a draft from the American Academy of Neurology in regards to their treatment practice guidelines in relation to medical marijuana. Cannabis-based medications should be avoided in children and adolescents, not only due to the paucity of evidence, but due to the association between cannabis exposure in adolescents and potentially harmful cognitive and affective outcomes in adults. Again, the 2 studies they showed, only adults, nothing in children. So again, we got to be very, very careful in regards to how we're answering the questions that the parents are coming with. Compared to placebo, cannabis-based medications are associated with the increased risk of short-term adverse events, dizziness, dry mouth, and fatigue. Now, they stuck in this last one. Physicians may consider treatment with cannabis-based medications and otherwise treatment-resistant adult patients with TS suffering from clinically relevant ticks. Level C evidence. Not that great, but again, in general, ticks tend to improve. So the fact that they're actually very, very resistant is just uncommon. I'm not saying it doesn't exist, but there are still treatment options out there, such as guanfacine, Topamax, D2 antagonists, even looking at VMAT2 inhibitors and tetrabenazine that I would try before I even consider. Plus, there's also other issues with it in that I'm not licensed to prescribe it. You have to be licensed, the patient has to be registered, you have to fit a symptom, and you have to fit a clinical diagnosis that both fits. It's all out of pocket, no insurance coverage. So again, you have to understand, and a lot of people don't know that. So in the end, my takeaway is that the evidence is limited, okay? And it's not that I'm against it by any means. We just need more studies if we're really going to look at this with more patients for longer treatment durations before we make a real consideration. This is just a summary slide. I'm not going to go into that. So I'm just going to go through quickly 2 cases of how a good transition occurs in a young adult and how a bad transition occurs. This is the exact same patient, and they're 18 years old, have the comorbidities with TS on different medications, okay? Last appointment was with the pediatric provider at 18. They talked about leading up to it, how we're going to transition, what your unmet needs are, who do you need to see, is it appropriate just for primary care, do you need to see a subspecialist in movement disorders? They figured that out, the referral's made, a good little summary letter, could be their last note, just a summary of where they are right now and their unmet needs. You make the appointment, all the medications are continued, and follow-up is very easy. How can it go bad? Well, I do see this sometimes. Take the exact same patient. They go away to college, they never talk about transition of care, they come back in the summer, they're 19 years old, they want to follow up with their pediatrician, I need to get my Concerta and my sertraline and everything renewed. Well, sorry, you're 19, you've aged out, like, you have to go find another provider. So then a new referrals place, waiting 3 months, they see a new adult primary care provider. They look at the chart, they see the patient, methylphenidate, this is only in kids. I don't feel comfortable prescribing a controlled substance. This is crazy. Like, no, I need to refer to a subspecialist. A neurologist has got to be the one to prescribe it. And so then you wait another 6 months as you wait for a referral to a neurologist. And lo and behold, the patient was incredibly stable. They've probably found difficulty in getting their medications. They're going back to college. They're having trouble concentrating, with their classes, maybe having some anxiety type of issues. And all this could have been prevented if there's just a clear discussion with the primary care provider leading up to it, okay? And really determining who they should see is the biggest thing. And a lot of that, honestly, comes down to access to care again. Do you have an adult movement disorder specialist who is well-versed in TS to take them on, or is it really just going to fall to the primary care doc? So closing thoughts, okay? Again, the biggest thing that I want you to take home from today is that it takes time to set this up. You need to have open discussions with both the parents and the children in terms of what their needs are going forward, what medications are necessary, and how to transition them. And at each visit, as an adult provider, even if I see methylphenidate, guanfacine, I always readdress how their symptoms are and the need. Can we potentially taper off the guanfacine? Can I get you off the Abilify because I see some subtle Parkinsonism with rigidity and bradykinesia? These are all things that I constantly reassess, and do we actually need this? And still to continue to provide the same exact support that we do for children in regards to local chapters, OT for CBITs, psychologists if they need some CBT for their anxiety and OCD. So here are the references, and that's really it. So wouldn't be without a lecture without showing our kids. So, Bear, sorry about that. I don't know how that got in there.
Thank you all again for your time and attention. We have about 5 minutes, so we can open it up to questions for all of our speakers. Have Jen, do you want to pass around a mic, and we'll have a mic up here for the speakers. We do want to get you out on time, so you have time for a break and you can eat lunch. And those of you who are coming back for the education session, that will start at 2 o'clock. But any other questions, we're happy to answer them now.
With respect to all the treatments, therapies, and management strategies that you've all discussed tonight, where would you focus the attention for managing rage?
Well, one thing I was thinking about so the question was about rage. When I mentioned the fight or flight system, it's just that. It's the fight or flight. And so I see a lot of young people with anxiety and OCD, and we think about escape and avoidance as the go-to strategy, but there are a lot of young people who manage their environment and their anxiety through rage and anger and opposition and tantruming. And it's very, very effective at controlling their environment and changing a circumstance that's uncomfortable to them. And as that behavior persists and goes unchecked, and a young person becomes a big person, that rage becomes much harder to contain and control. So I think ideally starting early with behavioral strategies, if possible, would be ideal. Any other?
Just speak that actually Eric Storch's group looked at family accommodation and rage, which was such a fascinating study. They looked at it in OCD, and they also looked at tics. And so this sort of gives us a clue that, in a sense, a child can train the parent with their explosive outbursts. All right. So, just to sort of emphasize that the caring accommodation of symptoms may just backfire, and now you have a explosive, rageful teen or adult.
We were talking about teaching a tick-neutral environment where you're not just trying to make it an environment where your tics are less likely to occur because of anxiety or whatever, but also I think people who care are also trying to figure out what's going on. Is your anxiety, escalating, or are they tired? Is there too much excitement going on? So I think, I guess my question is, it's not always that, right? Sometimes the tics are waxing and waning. So in this tick-neutral environment concept, it's important to not always draw attention, right? Because that can make it increase also, right? So just like, okay, I'm aware that this is happening, and just not constantly being like, so what's happening now? Are you more anxious now, or what's going, right?
That's a great point. I think, and Adam, come on down, because you talked about this, and one question I had, I think there's no perfect solution when we talk about, managing antecedents and consequences, but also not accommodating or lowering your expectations for your child. And that's absolutely right. If someone's getting upset, you don't want to say, what's wrong? Can we help? What do you need to do? Because then that's more attention, that's more accommodation. So finding that balance, I think, can be tricky.
And oftentimes we want to encourage kids to have a place to express themselves, right? And so oftentimes home is that place. Right? They're buttoned up at school and trying to really, really hard and just need a place to just kind of relax and let things go a little bit. So that I think that is part of it, right? Of, just we're not going to focus on the tics right now. We're going to focus on you just having a place where you can just be for a little bit.
I have a question. I'm wondering if there are any current studies or any studies, clinical studies on the whole plant marijuana, or was it just THC with regards to tics?
Yeah, it was just with the THC back in the early 2000s. So I believe there is a pharmaceutical company that is developing a novel molecule called ABX 1413. It's a monoacylglycerol lipase inhibitor that basically works through inhibition of that enzyme that then improves the endogenous receptor activation. So it's not an exogenous endocannabinoid, but it works through the endogenous pathway. And so I think they had a phase 1 trial in Europe that looked somewhat promising. And so obviously we just need more data in regards to their phase 2 studies. But that's the only one to my knowledge, other than the ones that I presented today, that have any pathway mechanism through the cannabinoid pathway.
I'm wondering if you have any guidelines for informing the kids that they have this. I mean, when they're really young, they may not know. I'm talking about like before teenage years. If there are any suggestions for whether they should be told, hey, this is part of a condition and here's more about it, or, like you were saying, tick neutral environment, just ignore it and kind of act like nothing's going on. I'm just wondering.
I think I often lean towards be open with your children about what they are experiencing. And there may be some exceptions to that. There may be certain reasons that you wouldn't want to overly accentuate, but I'm always for education first. One of my mantras when I do therapy is that there shouldn't be any surprises. That if a child's coming in and they don't know why they're coming in, that's not a good thing, right? They should know, I'm here to work on this, I'm here to work on this, or we're here to work on this is often something to sort of reinforce with families. So I think that that's something to consider.
For young kids, there's a picture book called Taking Tourette to School, which we find often for younger kids is a nice way to introduce it to the child with Tourette and to also classmates potentially as well. Because you need to have the language or some language to be able to understand what's going on with you. Because as I say, with older kids, and it's true with younger kids too, if you don't own Tourette, Tourette owns you. If you're going to try and cover it and not have language to understand it and to be able to explain it to yourself and to people who are close to you, it creates more anxiety, it's more harmful.
I would say even the decision to go see a treatment provider can be complicated. And if a parent calls me and says, my 5-year-old has just started blinking for 2 weeks and I'm really worried, can we make an appointment? I might say, let's wait, but I won't say, ignore it and it will get better. I'll just say, keep an eye on it. Don't pay too much attention or ask a lot of questions to your child, but just keep an eye. Notice if it waxes and wanes, what the triggers are. Are you noticing anything else? Any difficulty at school? Any anxiety? Paying sort of this educated observation. Again, maybe bringing the parents in before you bring the child in, because that first appointment is a lot of attention and some maybe inadvertent reinforcers. Going out to dinner after the appointment with your parent alone without your siblings is a lovely experience that was then just because you went to the doctor for your tics. So paying attention to all those variables. On the other side, if a young person has had tics for 6 months and they themselves are really bothered or worried about being bullied and it hasn't yet been a year, I'll say, come on in, let's practice a few strategies. You're motivated to learn how to manage this. Let's get after it and not wait till you meet that 1-year criteria. So it's just kind of looking at everything and the whole picture for the child. All right, thank you all. Really appreciate your time and attention.
Oh, and if everyone could please...
For those who are staying for lunch and for the afternoon program, the lunches are out there with the beverages and everything. And we've got a couple people out there who are going to, give you the right lunch. Make sure you get what you ordered, and if anybody wants, we might have a couple of extra. So if anybody, is hungry before they go. Thank you, but we had them ordered in advance, and the education program will start here at 2 o'clock this afternoon. Thank you.
And everyone can leave the evaluation forms at the front table outside. Thank you.
Yes.